Here's a 24-year-old young man, asymptomatic, active, heart murmur since childhood. He's got a bounding carotid pulse. He's got a that type of murmur. His ventricle's dilated. Diastolic dimension 64, systolic dimension is 44. He's got a bicuspid aortic valve. He's got severe aortic regurgitation. There's his examination. What are you going to do? Shoot his coronaries and then do AVR, do a left and right heart cath with an aortic root, give him nifedipine and follow up, or just follow up? Okay, here's the stem again. 64 diastolic dimension, 44 systolic dimension, severe aortic regurgitation. What are you going to do? Go ahead and punch in the answer. And let's see it. All right. I think we've got some learning to do here. 44-year-old woman, palpitation for 2 years, but good exercise tolerance, couple thousand PACs. Here's her examination, mid-systolic clicks and a late systolic murmur. Her echo says that her diastolic dimension is 48, her systolic dimension is 22, her ejection fraction is 66%. She's got bileaflet prolapse with a late systolic jet. ERO is 0.5 centimeters squared. 0.5 centimeters squared. So what are you going to do? Send her for mitral valve repair. Do a left heart and right heart cath with LV-gram. Give her a vasodilator or just follow her up? So for those of you, an ERO of 0.4 centimeters squared by echo is considered severe regurgitation. And here's her ERO 0.5. Okay, let's see what you would do. All right. 55-year-old man, completely asymptomatic, 3/6 holosystolic murmur, early diastolic filling sound, EF 58%, diastolic dimension 61, systolic dimension 41, flail posterior leaflet, severe MR, ERO 0.6. What would you do? Same lot. Repair, get more information, give her a vasodilator and follow up, or just follow up? Let's see it. Okay, so there's a difference between the two of them. Here's a 76-year-old man. He's had a sick sinus syndrome. He had a pacemaker placed 5 years ago. Now he's got progressive edema and ascites, unresponsive to large doses of diuretics. Venous pressure is markedly elevated with a huge V wave coming up. 2/6 holosystolic murmur. He's got a dilated RA and RV, severe tricuspid regurgitation. What would you do? Just do a whole tricuspid valve operation, remove the pacemaker, do a pericardiectomy, or do a TEE? Okay, let's see it. Okay. So now we hit regurgitation. And our objectives, as with stenosis, are number one, to recognize pathophysiology presentation, appropriate testing, and interpret the testing with mitral regurgitation. Number two is design a plan of care, including timing and type of intervention for patients with mitral regurgitation. Number three is to recognize the pathophysiology presentation, testing, and interpret the findings with aortic regurgitation. Number four, take these patients with aortic regurgitation and figure out what to do with them in terms of treatment and interventions. And then finally, we're having an emerging number of patients who are presenting with tricuspid valve disease, which used to always be only with the congenital folks, but now we're seeing them. So we need to recognize the presentation and testing and management options with tricuspid regurgitation, okay? So as we go through regurgitation, as opposed to stenosis, we have to break them down even further into acute regurgitation, chronic regurgitation, which we didn't have to do with stenosis. So let's start out and just show you this guy here who presents with the acute onset of dyspnea and orthopnea, hypotensive, tachycardic, rouse. He doesn't have much of a murmur at all. And his transthoracic echo shows a hyperdynamic left ventricle with mild mitral regurgitation, but he's got severe pulmonary edema. And this is a scenario that you're going to see not infrequently, but what you see is this discrepancy of severe heart failure with a hyperdynamic LV and soft or no murmur. And this goes back to what Geski's comment to you was in the patient with a papillary muscle rupture, is that many times you do not hear in severe acute mitral regurgitation a murmur, and many times the echo might not show things in terms of the severity of regurgitation by color flow imaging because of the fact that you can't see the heart that well. So you have to have a high index of suspicion in patients who present with severe pulmonary edema and a hyperdynamic LV that this might indeed be severe mitral regurgitation. Now, the etiology can be either chordal rupture, infective endocarditis, or ischemic heart disease. They have the pulmonary congestion. They have a third or fourth heart sound. And as Jeff said, the murmur may be soft, short, or even absent. And the reason for that is in chronic mitral regurgitation, you always have the continuous gradient between the left ventricle and left atrium. But in acute mitral regurgitation, the left atrial pressure may become so high that you no longer have any flow but detectable by Doppler echocardiography. The treatment of acute regurgitation, well, you treat with vasodilators and intra-aortic balloon pump, but as Jeff said, if they have a papillary muscle rupture, that's surgical intervention right away as soon as possible. If they have endocarditis, as Michael was talking about, if they have heart failure, you're going to operate. If they have a chordal rupture, it depends on the response to therapy. Now, the thing to remember, the take-home message to remember in patients with severe acute pulmonary edema, normal LV function, think severe MR. And if your transthoracic echo doesn't really show very much except for the fact that that ventricle's pumping away, get a TEE or cath. Okay, pretty easy for acute. Now, chronic mitral regurgitation. If we think about a patient with chronic mitral regurgitation, again, we have to look at the etiology, pathophysiology, clinical presentation, testing, natural history, and that will help us determine the treatment. The etiology of mitral regurgitation, we now want to break down into two large categories. We talk about primary mitral regurgitation as being a disease of the valve. We talk about secondary mitral regurgitation as being a disease of the ventricle. Now, when we have a disease of the valve, it can be either degenerative, which is mitral valve prolapse, chordal rupture, or rheumatic. When we think about secondary mitral regurgitation, it's either due to a dilated left ventricle, which you'll hear about more tomorrow in our heart failure talk, or ischemic, and Jeff talked to you about the patient with the inferior lateral infarction, posterior medial papillary muscle dysfunction, and mitral regurgitation that way. But those are two different animals, primary MR and secondary MR. The etiology is different, the presentation is different, and the treatment is completely different. So that's what I want you to remember about etiology, primary versus secondary. Now, as far as clinical presentation, this is going to go back. This is why we had that session on Saturday night about preload, afterload, and contractility. Because in valvular heart disease, you have to be able to understand the load imposed upon the ventricle by the valvular lesion. So remember, mitral regurgitation is a pure volume overload. Aortic regurgitation is a volume and pressure overload. So in mitral regurgitation, the preload is high. In mitral regurgitation, the afterload is low because you're ejecting into that low impedance left atrium. So if you think about your Starling curve and you lower preload and you increase afterload, your ejection fraction after an operation is always going to fall. And that has incredibly important implications as we think about the progression of disease in patients with mitral regurgitation. But remember, mitral regurgitation has an increase in preload, a decrease in afterload, which means the ejection fraction after you correct the mitral regurgitation is going to go down. Now, regurgitant lesions present a problem in terms of timing of operation. The reason they present a problem is because long-standing volume overload can cause incipient left ventricular dysfunction, which means the contractile state of the left ventricle is going down. And the problem is by the time symptoms develop, by the time they come to you with shortness of breath, left ventricular dysfunction may have already been have occurred. And once there is left ventricular dysfunction, the prognosis is poorer. So in all patients with regurgitation, think of them this way. Think of the survival on your y-axis and years on the left axis. But you'll have the onset of regurgitation. It may go for a number of years as they get progressive left ventricular dilatation in order to compensate for the volume overload. And then what happens at some point in time, that long-standing volume overload will cause incipient left ventricular dysfunction. And once they have left ventricular dysfunction, the prognosis is poorer. But if you wait for symptoms, which occurs after left ventricular dysfunction, the prognosis is even poorer still. So this background is what you need when you start to evaluate these patients with regurgitation. And remember, once there is left ventricular dysfunction, the prognosis is poorer with or without operation. Certainly once there's symptoms, they've probably kind of gone too long. So, what is the clinical presentation of a patient with chronic mitral regurgitation? Well, remember, you could have a prolonged asymptomatic interval. Once they become symptomatic, it's going to be low output pulmonary congestive symptoms. Remember that in mitral regurgitation, most of the severe regurgitation will have a holosystolic murmur. If you have prolapse with an intact chordal structure, you might have a late systolic murmur, but that can't be severe MR. And that early diastolic filling sound is the best physical examination finding to tell you that the mitral regurgitation is severe, because it means you got so much blood going back in the left atrium during early diastole that blood's flooding from left atrium to left ventricle, and it'll give this early diastolic filling sound. Testing. There's 5,622 articles on echo Doppler evaluation of the patient with mitral regurgitation. And you've got 56 different variables that people have written about. But in your practice, when you read read an echocardiogram on a patient with mitral regurgitation, you only need to know three things. Number one is, how does it affect the left ventricle? Number two is, what causes it? And number three is, how much is there? Now, the status of the left ventricle, even though we would like to use volumes, and in the future CT and MRI are going to be much better for us than that, at the present time we use dimensions. And the reason we use dimensions is we've got outcome studies with dimensions. So you can go in and you can do your fancy volume measurements, but we don't have enough data to help us determine therapy for patients with mitral regurgitation or timing of intervention in terms of volume, and we have to use dimensions at this point in time. Now, you then want to know is, what is the etiology of mitral regurgitation? And you have degenerative mitral regurgitation with mitral valve prolapse, and remember, in degenerative mitral regurgitation, you usually have an eccentric jet if it's severe, and the direction of the jet is opposite the leaflet. So if you have a posterior leaflet abnormality, it goes anterior. If you have an anterior leaflet abnormality, it goes posterior. If you have secondary mitral regurgitation or rheumatic mitral regurgitation, you're going to have a central jet of mitral regurgitation. And if you have ischemic mitral regurgitation that Jeff was talking about the second day, you're going to have a posterior laterally directed jet. So the direction of the jet on echocardiography can be useful in telling you what the etiology is. The etiology is also helpful to determine whether or not it's repairable, which is going to influence how you're going to treat these patients. Now, if it's primary mitral regurgitation, what you want to do is you want to see what leaflet is involved. And the leaflet that the surgeon can repair with the highest degree of confidence is going to be a flail posterior leaflet. If there's calcium in the annulus, they're not going to be able to do a good repair. If there's calcium in the leaflet, they're not going to be able to do good repair. So what you're looking at is what leaflet is abnormal and whether there's calcification in the annulus or the leaflet. So we talked about how does it affect the heart. You're going to use left ventricular dimensions for that. What causes it, you're going to use the different jet and find out what leaflet it is, and then you look at how much is there. Now this is an old slide that back in the old days, when color first came out, we used to look at the extent of the color jet in the left atrium to determine the severity of mitral regurgitation, but it really is inaccurate and misleading because there are patients with very thin eccentric jets who can have severe mitral regurgitation. There are patients with secondary MR whose jet fills the entire left atrium and whom it's only mild. So what you really want to do is you want to get down to quantitation. And tonight, Sunil Mankat is going to go over the quantitation using proximal isovelocity surface area, but I certainly would urge you that in your laboratory, you have quantitation of mitral regurgitation because in 2017, you need that quantitative number to help you determine timing of operation. So severe mitral regurgitation, echocardiographic findings, we used to use color jet, but beware that the color can be misleading. A regurgitant volume greater than 60, a regurgitant fraction greater than 55%, or an ERO greater than 0.4 centimeters squared by our quantitative measurements is considered severe mitral regurgitation. Remember, the color flow alone can underestimate or overestimate, and I even urge you that if you've got a discrepancy or a question there, go back to the cath lab, do your good old-fashioned left ventriculogram, and that'll give you one more piece of information as to the severity of mitral regurgitation. Remember, wide eccentric jets are usually severe. Central jets are usually not severe. And a special case must be remembered with mitral valve prolapse, that if you have only a mid to late systolic murmur, or you do your echo and you see it's a central late jet of mitral regurgitation, it's very rarely severe. And the other thing you should do is you should look at the left ventricular dimensions, because if the left ventricular dimensions are completely normal, it can't be severe chronic mitral regurgitation. The ventricle always has to dilate. So a problem we get into is that if an ERO looks like it's severe and it's a mid to late systolic jet and the ventricle's normal, you know that it can't really be severe and the quantitative is overestimating. So when you're reading your echoes or you're interpreting your echoes, you have to put everything together and do more than just get a single ERO. But if the left ventricular size and function are completely normal, you can't have severe mitral regurgitation. So in patients with clinical signs of severe mitral regurgitation and mild MR by transthoracic, remember you can underestimate it and get a TE or cath, but you can also overestimate it too by some of your quantitative measurements. Now, the natural history of valvular regurgitation is important. We do know that severe mitral regurgitation has a poor prognosis if untreated. And this has been shown in a number of studies that if you have severe asymptomatic mitral regurgitation, that 9 out of 10 patients are either going to die, develop heart failure, and require surgery by the end of 10 years. That if the regurgitation is truly severe, 9 out of 10 patients are either going to die, go into heart failure, or require surgery at 10 years. So it's a poor prognosis. We also know that the more severe the regurgitation, the poorer prognosis. And this is where our definition of severity comes out, that if indeed done properly, your ERO is greater than 0.4 centimeters squared, the prognosis is poor, and that's why we define severe mitral regurgitation. The treatment then is based upon our understanding of the pathophysiology with the load on the ventricle and the natural history. A couple things about medical therapy. In the absence of systemic hypertension, there is no indication for vasodilator therapy in the asymptomatic patient with preserved LV function. It was thought at one point in time that vasodilator therapy might decrease the regurgitation of blood going backwards and preserve left ventricular function, but the randomized trials have not shown any benefit, so you do not give vasodilator therapy if you're following a patient with severe mitral regurgitation. You give therapy if it's secondary mitral regurgitation because you're treating the left ventricle, but with primary mitral regurgitation, you leave them alone. Now, if you look at the guidelines, we've got a whole list of indications for mitral valve intervention for mitral regurgitation. And it's very, very difficult to go through these. So I don't want you to remember all of these class 1, 2A, 2B indications, but let's keep it simple. And keeping it simple means this. The indications for intervention are, number one, symptoms, and these are any symptoms, as opposed to mitral stenosis. Remember, it's severe class 3 or 4 symptoms. Mitral regurgitation is similar to aortic stenosis. Any symptoms, they've already kind of reached that place where they started to develop incipient left ventricular dysfunction. Left ventricular dysfunction. If they've already developed left ventricular dysfunction, you want to intervene, knowing that it's a little bit too late for the optimal intervention, but at least you're going to do better than if you leave them go. And then finally, we're going to talk about prophylactic to try to get to them before the onset of left ventricular dysfunction. So severe, now this is organic primary mitral regurgitation. Any symptoms, you go ahead and operate. Any symptoms, you go ahead and operate. So if you've been following a patient with primary mitral regurgitation, again, can't walk up 2 flights of stairs, that's a problem, you operate. The second thing is left ventricular dysfunction. Now, what is left ventricular dysfunction? Well, this goes back to understanding our pathophysiology and the effect of preload and afterload on the left ventricle. But remember, mitral regurgitation has that low impedance leak, so the afterload is down. They have the volume overload, so the myocardial performance is actually falsely increased, so that will lead to an increase in ejection fraction and an increase in end diastolic volume. That's what happens in mitral regurgitation. What that means is that a, quote, normal ejection fraction in a patient with coronary disease of 55% is abnormal in a patient with severe mitral regurgitation. And we know that from outcome studies that show that if, in fact, the ejection fraction is less than 60%, they've already developed some incipient left ventricular dysfunction, and their outcome is poorer. The end systolic volume, or the end systolic diameter, is another beautiful measurement of systolic function. Because remember, we talked about the pressure volume loops in that maximal elastance line, and the ventricle only contracts to a certain level. So an end systolic dimension of greater than 40 millimeter is also a sign of left ventricular dysfunction. So in patients with severe primary mitral regurgitation, left ventricular dysfunction is an ejection fraction less than 60% or an end systolic dimension greater than 40. Okay? So this is a 60-40 rule that you use in primary mitral regurgitation. So if we go back to this graph that kind of talks about the pathophysiology and the progression of disease in patients with mitral regurgitation, remember you have the onset of severe mitral regurgitation. If they've already developed symptoms, well, you're going to operate, but you like to do it before that. If they've got left ventricular dysfunction, you're going to operate, but you'd like to do it before that. And if you operate, they're going to be better than if you leave them. But what you'd really like to do is get them before left ventricular dysfunction and symptoms. So anybody with symptoms, anybody with left ventricular dysfunction, you operate. But if we can do something before the onset of that, that's what we want to do and try to get to that ideal time to operate. Now, we never did that in the past because 20 years ago, all we had was a mitral valve prosthesis, and Jeff's going to talk to you about all the complications of a prosthesis, especially in the mitral position, and probably at that time the operative risk was 5 to 8%, so it really didn't make sense to operate sooner rather than later. But what we have now is we've got surgeons around the country who can do a mitral valve repair in severe primary degenerative mitral regurgitation with an operative risk of less than 1%, and in many places the success rate for repair can be over 90 to 95% with excellent long-term outcomes. And Rakesh Suri from our institution actually just about a couple years ago showed that in a group of patients who underwent early operation for mitral regurgitation versus those who had medical management, the long-term outcome is actually much better because you can get to these patients before the onset of left ventricular dysfunction, before the onset of symptoms. And that's critical in these patients because what happens many times if they wait too long, they come to you, they have their mitral valve done, and their post-op EF is 30% and they still have multiple problems. So it's reasonable to consider operation in asymptomatic primary MR if truly severe MR, so you have to make sure it's severe, it's not that late systolic prolapse. If your surgeon can do it with a low operative risk and there's a high chance of successful repair, which is why I emphasize looking at the echocardiogram, and if you've got a posterior leaflet flail, no calcium in the annulus, no calcium in the leaflets, and a good surgeon, you want to go ahead and operate early before the onset of left ventricular dysfunction. Now, everything we talked about was for primary mitral regurgitation. Secondary mitral regurgitation is a different animal, either due to a dilated left ventricle or ischemic mitral regurgitation, because it's a disease of the ventricle and not a disease of the valve leaflet. And if you go ahead and you try to intervene on these patients, chances are you're not going to help them long term because their ventricle's only going to get worse and worse and worse. So the indication for intervention is unclear, but I would say you should reserve it for severe mitral regurgitations with symptoms unresponsive to the best guideline-directed medical therapy of the left ventricle, which not only includes beta blockade and ACE inhibitors and aldosterone antagonists and maybe ARNIs now, but also resynchronization if they do meet the criteria for that. So don't intervene early on a patient with secondary mitral regurgitation. Now, for ischemic mitral regurgitation, a couple randomized trials have come out that you need to be aware of is that if you indeed have severe ischemic mitral regurgitation, the surgeon should do a mitral valve replacement because if they try to repair, it's going to break down and they're going to have problems. The second thing is if you're undergoing bypass alone and they have concomitant asymptomatic moderate MR, the outcome is probably better if you leave the MR alone because most of them the MR will get better if you treat the ischemia. So 2 randomized trials that just came out that kind of help guide you with the nuances of ischemic mitral regurgitation. Now, as with aortic stenosis, the cath lab people are going to want to try to do something to take the place of the surgeon. Right now, we have the Alfieri stitch. In the future, there's going to be some really neat percutaneous valves, but we're not at the point now where anything percutaneous is anywhere near as effective as a good mitral valve repair. There is no catheter-based mitral surgery, mitral intervention that is anywhere as good for both acute and long-term outcome as a well-done mitral valve repair. So for the percutaneous clip now, remember you're probably going to have residual 2+ mitral regurgitation in the majority. The indication now is for primary MR in a patient with severe symptoms who would be at a very high risk for surgery, And if they're at a lower or intermediate risk for surgery, I'd send them for surgery. We don't know what's going to happen in secondary MR, and in another year or so, we'll have a couple randomized trials to tell us whether we should do it in a dilated ventricle or ischemic ventricle. So we covered mitral regurgitation, a few words about the acute and the chronic. Now let's turn to aortic regurgitation. And again, in aortic regurgitation, a few words about acute. Now, acute severe aortic regurgitation is a large volume overload superimposed on this unprepared left ventricle. So you don't have acute enlargement, you decrease your effective stroke volume, you have a rapid rise in diastolic pressure, you have tachycardia which can't compensate, you have this type of a pressure here. Take a look at this left ventricle, rapid rise in diastolic pressure, rapid drop in aortic pressure, so you have almost equalization of pressures right there. What happens then is because of that, your murmur might not be loud, it might be short or even inaudible. And aortic regurgitation, you have to add another component in there and divide them into not only acute and chronic, but root and valve. And if you have a root aortic regurgitation, that's dissection. If you have a valve severe acute regurgitation, that's Mike Cullen's endocarditis. Remember, they get really sick, pulmonary congestion. AR may be soft, short, or even absent, may not have the bounding pulses. If they have a dissection, they go right to the OR. Remember, do not put an intra-aortic balloon pump if there's aortic regurgitation. Do not put an intra-aortic balloon pump in if they have aortic regurgitation, no matter how shocky they are. Do not put an intra-aortic balloon pump in because you're increasing your afterload, making it worse. Nitroprusside and inotropes can be used. Pressors are contraindicated. Beta blockers are contraindicated. And that's all you really need to know for acute mitral aortic regurgitation. And as Michael said, in acute aortic regurgitation due to infective endocarditis, if they go into heart failure, you go to the OR right away. Now, let's turn to chronic aortic regurgitation. And as with acute aortic regurgitation, you have to look at the etiology, and again, you divide it into valve and you divide it into root. The valve is pretty similar to that of aortic stenosis. The root is everything that Juan Bowen talked to you about, that anything that dilates the aortic root can cause aortic regurgitation. Now, again, you've seen this before, but I think this is critical for your understanding of timing of operation. Know the load that's imposed upon the left ventricle by the valve disease. So in aortic regurgitation, you have both a volume overload as well as a pressure overload because you're trying to get this huge volume of blood going out through a normal size aortic valve. So your preload is up because of the volume overload, but your afterload is up as opposed to mitral regurgitation. If your preload is up and your afterload is up and you replace the valve, your ejection fraction is not going to change. This is significantly different from mitral regurgitation, and it leads to a different group of indications for operation. So your ejection fraction in a patient with aortic regurgitation is actually going to reflect what the ventricular intrinsic contractility truly is. So that's the difference between aortic regurgitation and mitral regurgitation. The clinical presentation of aortic regurgitation is usually have a very prolonged period that's asymptomatic with some incipient dyspnea, and the reason for that is with exercise you're decreasing your diastolic filling period, so you're actually decreasing the amount of aortic regurgitation. Your physical examination, you're going to get a short flow murmur in systole, but a long diastolic decrescendo murmur, and you may have an Austin Flint murmur. Now, the most consistent finding in severe aortic regurgitation is the wide pulse pressure. So if you have a diastolic pressure less than 60 millimeter of mercury, you can be pretty sure it's severe aortic regurgitation. You might not have that with what a nurse gets by a machine cuff, and that's why I have the fellows personally measure with a blood pressure cuff the blood pressure in both arms, especially in severe mitral aortic regurgitation. These are all of the physical examination signs that you don't have to remember. Just remember that there's a whole lot of volume going out, so you can get these bounding pulsations in all of the arteries. Now again, if you have a bicuspid aortic valve as an aortic stenosis, if you have hypertension, think coarctation. If there's chest pain, think dissection. You're going to see this little theme come out again and again and again. Bicuspid valve, aortopathy, dissection, and coarctation. Now the testing in aortic regurgitation, similar to mitral regurgitation. How does it affect the heart? What causes it? How much is there? Remember the echo assessment. You want to look at the end diastolic dimension and systolic dimension and ejection fraction. For the echocardiographic determination of severity, the isovelocity surface area isn't as easy to do in aortic regurgitation. So you can get your regurgitant volume, regurgitant fractions in ERO, but you want to look at other things like flow reversal in the descending aorta and the jet dimension. And many times you might have an eccentric jet like this, in which it's very difficult to know the area of the jet. But if you have a mitral inflow velocity that has a very short half-time, and you've got this very, very large, let's say, reversal in the descending aorta, that's probably a better sign of severe aortic regurgitation than any of our quantitative measurements. Remember, the echo color flow alone can underestimate or overestimate, and if you have any doubt, take them to the cath lab, do a root. If you do a root, inject 60 cc's of contrast at 20 cc's per second. You need a lot of contrast in there to see it. So in a patient with aortic regurgitation and wide pulse pressure on examination, if you suspect that they have severe AR and the echo doesn't confirm it, get an aortic root. Now, treadmill testing was used a lot in patients with aortic regurgitation to try to look for incipient left ventricular dysfunction. We don't use it anymore. It's useful to get an objective measurement of exercise capacity, but all of this data 15 years ago where you look at the change in EF with exercise really doesn't mean anything. Natural history. Regurgitant lesions, same thing. Onset of regurgitation, long period where you have progressive left ventricular dilatation. At some point in time, you have left ventricular dysfunction in the onset of symptoms. What is left ventricular dysfunction in aortic regurgitation? Well, it's your EF that's normal in your laboratory. So in our laboratory, an EF greater than 60%, greater than 50% is normal, and those patients do well. But after an operation, if the EF is less than 50%, they'll do poorly. So there'll be a poor outcome with a low EF or a huge LV, which is an end systolic dimension greater than 50. Now, if we think of treatment, we think of medical therapy first, and there were some original papers talking about vasodilators in aortic regurgitation. But the more recent studies have not supported the use of vasodilators in aortic regurgitation. And what we would say is that chronic treatment for patients with symptoms and or EF less than 50% who are not candidates for AVR get their treatment for LV dysfunction. And if they have hypertension, you should give them vasodilators. But in a patient that you're following with severe aortic regurgitation who doesn't have hypertension, there's no role for vasodilator therapy. Now again, if you go to the guidelines, you see this huge list of indications for operation for aortic valve regurgitation. But again, let's simplify things. And the simplification is symptoms, LV dysfunction, and LV dilatation. Symptoms, any symptoms, aortic regurgitation, you operate. LV dysfunction, you operate. LV dysfunction, remember, because of the preload and afterload changes, is what is a normal ejection fraction in your own laboratory. If your normal ejection fraction is 55% or less, you use 55. If it's 50% or less, you use 50. So LV dysfunction, you're going to go ahead and operate. But if you wait for LV dysfunction, it's okay. You don't have to worry about the prophylactic. because the drop in ejection fraction in aortic regurgitation occurs before irreversible left ventricular dysfunction, this concept called preload reserve afterload mismatch. This is what I mean by this, and this is another important concept. You have severe aortic regurgitation. Okay, now with the severe aortic regurgitation, what then happens is you have left ventricular dilatation. The left ventricular dilatation can go for years and years and years, and then you have afterload mismatch, where the ventricle can't dilate enough to accommodate the afterload, increased afterload. And it's only after the afterload mismatch will you have irreversible left ventricular dysfunction. So if you think about it, the LV dilates, the EF will drop when you have afterload mismatch, but irreversible left ventricular dysfunction will occur after the ejection fraction drops. This is opposed to mitral regurgitation. One of the major differences with mitral regurgitation is because of the change in load, what you can do is you can actually wait till the ejection fraction drops before you operate. So again, with aortic regurgitation, you'll have multiple numbers depending on who you read and what paper you have and who's going to be looking at it. But to simplify it, I would say operate in aortic regurgitation for number one, any symptoms. Number two, ejection fraction less than what's normal in your laboratory. And number three, an end systolic dimension greater than 50. So if you want to use that 50-50 rule for aortic regurgitation, remember it's different from the 60-40 rule in mitral regurgitation. Couple caveats: if you can normalize it, the body surface area, instead of 50, you can use 25 millimeter per meter squared. And remember, you replace the aorta with a bicuspid valve if it's greater than 2.5 centimeter per meter squared. So if you kind of summarize regurgitation, it actually turns out to be pretty easy in terms of timing operation. First of all, you have to make sure it's severe, and any symptoms in either aortic regurgitation or mitral regurgitation, you're going to operate. Any symptoms. Now, you also operate if there's a drop in ejection fraction, which is less than 60% in mitral regurgitation and less than 50% in aortic regurgitation. And then you look at the end systolic dimension. If it's greater than 40 millimeter in mitral regurgitation or greater than 50 millimeter in aortic regurgitation, you operate. So there's a 60-40 rule in mitral regurg. There's a 50-50 rule in aortic regurg. But remember, because mitral regurgitation develops this incipient left ventricular dysfunction that you might not be able to detect if you have primary MR and a repairable valve, you'd probably operate even before the onset of any of these parameters. A couple things about tricuspid regurgitation, because we're going to be seeing more and more of these patients with tricuspid regurgitation. Again, you look at primary valvular versus secondary tricuspid regurgitation. And one thing you should realize in your own practice that our fellows have really written some nice things about is that the two patients that you're going to see more and more of with severe tricuspid regurgitation are, number one, patients with pacemaker leads in place, and number two, for some reason, women, older women with long-standing atrial fibrillation will get this annular dilatation. They can cause severe, intractable tricuspid regurgitation. The history, of course, is edema, ascites, and fatigue, and on examination it's going to be those big, huge V waves you see in the neck, and you might not hear a loud murmur. On echocardiography, you can see a large jet, but what you really want to see for severe tricuspid regurgitation is this dagger-shaped low-velocity TR signal, which means the right atrial pressure is coming and just meeting right ventricular pressure, or a large systolic reversal in the hepatic veins, which is just showing you those large V waves in your neck. Now, no one knows when to operate. There's nowhere limited data, but I would say that if they have severe symptoms unresponsive to diuretics, if it's severe at the time of left-sided surgery, even if it's only moderate at the time of left-sided surgery, if the annulus is greater than 4 centimeters, have your surgeon do an annuloplasty ring. Remember the pacemaker leads, though, don't try to pull out the pacemaker leads because about 2 out of 3 times the pacemaker lead might be entangled in the tricuspid valve. You pull that sucker out, you're going to make things a whole lot worse. You send them to surgery, they'll put in a valve or they'll displace the pacemaker lead into the commissure and exteriorize the pacemaker lead external to the valve. So severe intractable tricuspid regurgitation due to a pacemaker, you send them to surgery. Operate or repair the tricuspid valve, exteriorize the pacemaker lead, and if they have atrial fibrillation, try to get them back to normal sinus rhythm first, because many times the tricuspid regurgitation will go away. So that's the regurgitation. Remember that in aortic and mitral regurgitation, you have to divide it into acute versus chronic. And then in aortic regurgitation, you have to look valve versus root. And tricuspid regurgitation is an emerging disease that we're going to be seeing more and more of, and you're going to be hearing more and more how to manage these patients. Now, with Michael sitting down, let's just go right to the cases, and we'll go from there.
All right, so we have a 24-year-old asymptomatic active man. He's had a heart murmur since childhood. He's got bounding carotids, a 2 out of 6 systolic ejection murmur that peaks early, and a 3 out of 6 long diastolic decrescendo murmur. On an echo, he's got an EF of 59%. He's got a bicuspid valve. He's got a mean gradient of 12, and a severe aortic regurgitation with an LV end diastolic diameter of 64 and an LV end systolic diameter of 44 millimeters. What would you do? All right. What do you think, Nish? 76%.
Not good enough.
Yeah.
Think about valvular regurgitation, okay? And this just summarizes everything I said in the one slide, that any symptoms or asymptomatic with volume overload and left ventricular dysfunction. So in MR, it's an EF less than 60%, end systolic dimension greater than 40. In AR, it's an ejection fraction less than 50 and an end systolic dimension greater than 50. So this person had an EF of 59% and an end systolic dimension of 44. Chances are the guy's going to go another couple decades or even 3 or 4 decades before he needs anything done. They just accommodate so well. And in these younger people, you don't want to put in a prosthesis unless you really, really have to. It's not like a repair where you go early. This is a prosthesis with all the complications that Jeff's going to talk to you about a prosthesis.
All right. We had some questions come in about acute aortic regurgitation. You obviously mentioned not to put in a balloon pump. Would you ever pace them to increase their heart rate and decrease the regurgitation? Is that ever something you've seen happen?
You could.
Yeah.
And we've actually turned up pacemakers to the pacemakers that come in, but actually I think to take the time to put in a pacemaker might not be the best thing. But if they have a pacer in place, that'd be a good thing to do.
Gotcha. And then the other question that came in, what if you have combined AS and AR? And say moderate AS, moderate AR, does that change your approach to these patients?
It certainly does. So if you look in the guidelines, there's just a very short thing on combined lesions. And what had happened was nobody wanted to write it because nobody knows anything about it. But what we do have is Alexander Egby from our institution here has recently published the outcome of combined moderate AS and moderate AR together and found out that their outcome is similar to that of severe stenosis. So this is a very good point. I would take the moderate AS and moderate AR and treat them like aortic stenosis.
Gotcha. Good. All right, should we go to the next one here? We have a 44-year-old woman who's had palpitations for 2 years, but she has a good exercise tolerance. She's got 2,000 PACs on her Holter. Her exam, JVP and carotids are normal. Her LV is not displaced. She has multiple mid-systolic clicks and a 2 out of 6 late systolic murmur. On her echo, her LV end diastolic diameter is 48, LV end systolic diameter is 22, EF is 66%. She's got bileaflet mitral valve prolapse, a late systolic jet, and they give you an ERO of 0.5 centimeters squared. What is the next step? 81% said reassurance and follow-up. How we doing here?
Why only 81?
Yeah.
Here's an example of what this looks like. And you see the jet, if you just stop the jet, it looks like it's, about half of the left atrium, and the ERO sometimes looks like it's very, very high because you're only measuring in late systole. But really, the chordae are intact, and the left ventricular size and function are completely normal. You know this person doesn't have severe MR. This might be why the outcome of operation is so good in some patients. But and we've seen that. But seriously, don't get fooled with numbers. Again, use your head, put everything together, and you can't have severe MR with a normal left ventricle, a normal left ventricular size.
Right. Now, let's say this patient, let's say this 44-year-old woman, let's say she goes into AFib.
Yeah.
Okay. Does that A, change your approach to the MR, and B, she's otherwise low risk, her Chad's VAS score is 0, what do you do about anticoagulation?
Yeah, those are very good questions. If the MR isn't severe, and you have to be absolutely sure it's not, then you treat them just like you would anybody else without much regurgitation.
Okay. Do you anticoagulate?
You always anticoagulate to start with, but long term, I probably would not with just mild MR.
Okay, good. All right. Should we move on to the next question then? So here we have a 55-year-old man, completely asymptomatic. Carotids are low volume on exam. He's got a 3 out of 6 holosystolic murmur and an early diastolic filling sound. On echo, he's got a dilated LV with an EF of 58%. LV end diastolic diameter is 61 with an LV end systolic diameter of 41 millimeters. He's got a flail posterior leaflet, severe MR with an ERO of 0.6 centimeters squared. So what is the next step? I think that's a round of applause.
They can do it.
They can do it.
Yeah, so the thing about this guy is, remember that his EF, even though it would have been normal if he had coronary disease, is down. And that end systolic dimension is a really nice way to accurately tell that the ventricular function is starting to deteriorate. And, even if the ventricle was normal with that severe MR and you got a good surgeon, you probably want to intervene before anything would happen.
Right. So some questions have come in about secondary MR. We outlined some criteria for assessing the severity of primary MR.
Yeah.
How do you assess the severity of secondary MR?
That's been very controversial. The first set of guidelines, we took the tack that with the definition of severe, you should say it's severe when the prognosis starts to deteriorate. And Marie Serrano from our institution showed that the prognosis is much poorer with an ERO of 0.2 centimeters squared. We actually had to change it this year because all of our outcome studies are based on EROs of 0.4 centimeters squared. So if we're going to apply outcome studies to severity, severe secondary MR is 0.4 centimeters squared.
Good, thank you. All right, let's go to the next question. 76-year-old man, past history of sick sinus syndrome, had a permanent pacemaker placed 5 years ago, now with progressive edema and ascites, unresponsive to large dose diuretics. He's got a JVP of 25 millimeters with a large V wave and a 2 out of 6 holosystolic murmur. His echo has normal LV size and function with a dilated RV and RA, and he has severe TR with loss of central coaptation. What would you do?
Let's see. How many people in the audience, raise your hand if you've had one of these patients with severe TR and a pacemaker? Now, this is fascinating because about 8 years ago, I went to our pacemaker people and I say, your pacemakers are causing severe TR, and they said, never happens. Now we know it does.
Yeah.
Okay, let's see what you would do. %. Almost. Almost.
Almost doesn't cut it, though. Doesn't cut it.
But you don't need a TE. You know, it's wide open, severe TR. Go ahead and get them operated on, and they're going to do much, much better.
Okay.
Okay, any other questions from the regurgitation?
One question about acute mitral regurgitation.
Yeah.
So what do you tell the surgeon? So you've got a patient who goes into
Well,
flash pulmonary
you
edema.
never tell the surgeon anything.
How do you communicate with? You've got a patient that goes into flash pulmonary edema. You can't hear a murmur. You don't see anything on the echo. What's your line of communication there? Because you understand that something needs to be done.
Oh, Geske had this. Remember that little phone call to that
Yeah.
mad surgeon? Before you send him to surgery, you have to demonstrate what's going on.
Right,
So if your transthoracic doesn't show it, you got to get a TEE before you call your friendly surgeon.
Okay, came
so-
up. So good.
And actually, you can tell the surgeon what to do.